The time is now 12:02. Again, my name is Cassietta Trawick. I go by Cassie. I'm one of the admission counselors here at the Scott Weatherhead School of Public Health and Tropical Medicine at Tulane University. And today I have the honor of introducing our DRPH candidate, Ms. Denise Symonette Mitchell, and she'll be presenting her public health discovery seminar series on contours of care, a public health perspective on pediatric food allergies. We'll have Q&A session at the end. So if you have any questions, feel free to drop them in the Q&A chat, just in case, you have to log off a little early. And so I'm going to let Ms. Denise take it away.
Fantastic. Thank you so much, Cassie. Welcome, everyone, to Contours of Care, a public health perspective on pediatric food allergies. Here on your screen, you see a QR code. And Cassie, if you could please drop a link in the chat as well for those who may be unable to access the QR code for any reason. This is a very quick pre-session survey. I will give you 2 minutes to complete that. All right, wonderful. Welcome, everyone. And Cassie, please help out with the chat if you see any questions regarding accessing the pre-session survey. So welcome, good afternoon. Today, I'm so delighted that you all have joined me for Contours of Care, a public health perspective on pediatric food allergies. My name is Denise Symonette Mitchell, and as you heard, I am a Doctor of Public Health student at the wonderful Tulane University Celia Scott Weatherhead School of Public Health and Tropical Medicine within the Department of Social, Behavioral, and Population Sciences. I'm also a very, very proud HRSA-funded maternal and child health doctoral training scholar. I serve as a research assistant on the NIH-funded SHRIVE study within the Department of Epidemiology. And throughout my tenure here, I've previously served as a teaching assistant across various departments within the School of Public Health. Most significantly, though, I am also a mother. I am a mom to Salon Mitchell III and Daxon Mitchell. You see them pictured here. We reside in the Washington, D.C. metro area, where I've spent the past 10 years working as a federal lobbyist. So I believe that the personal is political, which is why I like to bring in that side of my work as well. Let's jump right into the agenda. First, we will cover learning objectives, and then we'll set the stage, providing a background and lit review, which is when we'll dive into the epidemiologic context and the clinical urgency of this matter. We'll then jump over to strategies and solutions, which will provide us with the framework and policy levers, including structural competency and federal legislation, and we will end with a case study. So, to honor the full arc of this session from epidemiology to structure to practice and to also sustain the integrity of that progression and the time, I know it's many of your lunch breaks, I'll hold all questions until the end. So if anything arises for you along the way, an insight, a critique, or even a point of tension, please make note of it and we'll return to those reflections during the latter part of this presentation, during the discussion period. And I will try to answer the questions through a structural lens. So here are our learning objectives, and they anchor our session and help us move forward together with intentionality. So I invite you to see them as scaffolding for today's session or guideposts, as each objective reflects a different dimension of structural competency, knowledge, analysis, and of course, application, because that's what the DRPH program is all about, the applied practice of public health. So first, we will define structural competency and its relevance to pediatric food allergy care. We will analyze how the arc of care reflects systemic inequity in allergy diagnosis. And as you may know, arc of care refers to the cumulative diagnostic trajectory, which is shaped by decisions and delays at each step. For example, from symptom onset to specialist referral. We will then go into an applied case-based reasoning to recognize the structural factors that have shaped clinical decisions in the past. And as you may know, case-based reasoning examines a specific clinical case to identify problems, patterns, and of course, solutions. It leads us to understand not just what happened, but why. So, pediatric food allergy is an immune mediated condition. It is one of the most common chronic childhood conditions. Raise your hand. Let me see an emoji if you or someone you know has been impacted by food allergies. Yes, yes, yes. It is a very common. And believe it or not, here in the United States, a food allergy triggers an emergency room visit approximately every 10 seconds. And that is collectively across all demographics. Again, a food allergy triggers an emergency room visit approximately every 10 seconds. So that means about 6 people have had those experiences during the first minute of this presentation. And to provide additional context, food allergy is an immune mediated reaction where the body identifies a specific food, for example, peanuts, as a harmful invader and produces antibodies against it. Symptoms can range from the mild, like hives, itching, swelling, to severe, which would include anaphylaxis, which is what happens when your immune system releases a flood of chemicals that causes one to go into shock, thus causing two or more organ systems to fail. And reactions typically occur within minutes, but in other cases, like FPIES, it could occur hours after consuming the trigger food. So this work, Contours of Care, conceptualizes pediatric food allergies not as isolated by a medical event, but as clinical indicators of structural inequity embedded within the U.S. healthcare system. It argues that racial disparities in diagnosis and management are not peripheral. They expose deep fault lines within the public health system and reverberate across all 5 domains of the social determinants of health. For this reason, Contours of Care posits that food allergy is a significant and growing public health concern. National data estimates that 1 in 13 children are affected, and that's approximately 2 children in every classroom. As the Food Allergy Research and Education nonprofit, or FAIR, reminds us, it's a disease. Food allergy is a disease, not a diet or a lifestyle choice. Over 40% of children with food allergies have experienced severe reaction, and 29% of reported childhood anaphylaxis cases occur in schools or childhood cases. That's about 1 in 3. This underscores the urgency of system wide preparedness rather than parental vigilance alone. As you may know, for Black children, these gaps deepen. They are twice as likely to experience a severe allergic reaction requiring emergency department care, and their associated healthcare costs are roughly 2.5 times higher than those managed in outpatient settings, like with an allergist. These are not random outcomes, I believe. They are patterned reflections of structural failures across the healthcare continuum. Within the literature, it is well established that geography, school resources, and institutional preparedness profoundly shapes the outcomes. And this is illustrated colorfully and richly in a research study conducted by Dr. Carla Davis within the Houston Independent School District, or Houston ISD, where they found that while most schools had students with diagnosed allergies, fewer than half had epinephrine auto-injectors on site. Epinephrine auto-injectors, or for short, EpiPens. Higher SES schools were 6 times more likely to have epinephrine available, and that's even after controlling for the number of diagnosed students, which is a stark demonstration of how inequities and resource allocation perpetuate risk. As a reminder, nearly 1/3 of all reported childhood cases of anaphylaxis occurs in school-based settings, and under-resourced schools are 6 times least likely to have emergency care available on site? Well, disparities persist even when controlling for insurance status and socioeconomic factors, demonstrating that the issue is not access but quality of care. These inequities are maintained through institutional norms, diagnostic inertia, and limited structural awareness within clinical training. Moreover, research consistently shows that Black children have higher prevalence of food allergies, yet remain underrepresented in clinical studies. Together, these patterns make clear that while awareness can shift, structures endure. And that's what we're here to address today. So I completed a literature review, and before we turn to structural competency and begin exploring the broader policy levers, let's briefly anchor ourselves in what the literature already reveals about the scope, the causes, and the attempted solutions to racial disparities in pediatric food allergy diagnosis and care. So Jiang and colleagues conducted one of the largest studies to date, which was a nationally representative cross-sectional survey of over 51,000 U.S. households to examine racial, ethnic, and socioeconomic differences in food allergy prevalence and outcomes. So they applied a very, very stringent convincing food allergy criteria, which combined both self or parent-reported reactions with IgE mediated symptom history to ensure diagnostic accuracy of their findings. So, this national data set helps us see inequity not just in who has food allergies, but who receives a confirmatory diagnosis, treatment, and follow up care. And their findings revealed that Black, Hispanic, and Asian children experience higher rates of multiple food allergies and severe reactions, while lower income households are least likely to hold active epinephrine autoinjector prescriptions or EpiPens. So these trends highlight a quality of care gap and not just simply disparities in access. The Springsteen study developed the Food Allergy Comprehensive Tool, or FACT, to evaluate pediatricians' knowledge and confidence in allergy management. So they used a pre and post test design, and an intervention led to measure gains in knowledge and confidence, demonstrating that concise educational tools can improve provider competence. Structural competency is an educational tool or intervention. It should be noted, though, in the Springsteen study, the intervention worked. It did boost provider knowledge and confidence, but it did not examine structural contributors or equity outcomes, which again reminds us that education alone, without systems reform, cannot, will not, and has not closed the gaps. Next, with the equity curricula in action, we've got the Perdomo study. So Perdomo and colleagues implemented health equity rounds, which was a case-based interdisciplinary conference series at the Boston Medical Center. And that was used to analyze how racism and structural factors shape clinical care. Participants reported increased comfort discussing bias, equity, and socio-political context, which then showed how reflection, which we will have toward the end of this session, how reflection and dialogue can reorient medical culture. And lastly, but certainly not least, we have the Udimba study, where she and colleagues extended this approach within the field of allergy and immunology. And they developed a multi-institutional structural competency curriculum for fellows, faculty, and clinician scientists. Participants demonstrated increased confidence identifying and addressing structural drivers of health disparities. So Perdomo's health equity rounds and Udemba's structural competency curriculum both demonstrate how case-based learning, like we are exploring today, can reorient medical education toward racism inequity, which shows promising results. And as you may know, or perhaps not, Dr. Udemba actually completed her residency at the School of Medicine here at Tulane. And that's also where I applied this research toward the latter part of last year. but that will be for seminar 2. So, transitioning to the next session, together these studies make one truth undeniable, and that is while knowledge and awareness can shift, once again, as I've already stated, structures endure. And that's precisely why our next section turns to structural competency as both a sustainable and a scalable framework for institutional change. So I also completed a root cause analysis to further explore the racial disparities in pediatric food allergy diagnosis and care. And with my root cause analysis, I identified 4 categories of contributing factors to the delayed diagnosis of food allergies in Black children. First was provider knowledge and training, followed by healthcare system infrastructure, policy and institutional policies, priorities, excuse me, and lastly, patient community context. I then completed a priority analysis. I conducted that to determine which of those should be addressed first. And I decided upon the lack of equity focused legislation addressing food allergies and insufficient structural competency education. Raise your hand if you are familiar with structural competency. Okay, very good, very good. So, structural competency was developed by Dr. Jonathan Metzl, who is an MD, PhD psychiatrist, sociologist, and Dr. Helena Hansen, who's also an MD, PhD psychiatrist, anthropologist. I do believe that their training really informs the expansiveness of this work. So, structural competency emerged as a concept in their 2014 article that was titled Theorizing a New Medical Engagement with Stigma and Inequity. And in the seminal article, the scholars proposed a paradigm shift for addressing structural inequities in clinical training and decision making. You may be pleased to know that structural competency has been successfully applied in fields like obstetrics and gynecology to analyze how institutional racism, policy constraints, and economic disenfranchisement shape clinical outcomes. It's been applied to primary care, and this lens has exposed how prescription patterns are influenced by zip code linked social conditions rather than pure clinical indication. It's been applied to nephrology, and that's when they explored the inequitable dialysis referrals that were traced to institutional practices and implicit bias and not patient behavior alone. In emergency medicine, structural reorientation has challenged narratives of noncompliance and inspired audits of triage patterns. And lastly, in dermatology, this lens has led to an inclusive medical image libraries and deeper understandings of how race is depicted in training materials for our country's clinicians. So the structural competency framework illuminates the why behind treatment gaps, positioning providers to disrupt, not replicate structural harm. So let's begin with structural recognition. And this is when we are recognizing the structures that shape clinical interactions. This is defined as the ability to identify and make visible the institutional, policy, and infrastructural forces that shape health outcomes, particularly for historically and systematically marginalized communities. Some people in the past may have referred to this group as minorities. The key concept here is that clinical outcomes are shaped by more than patient behavior alone or even provider knowledge. They're shaped by laws, zoning, access to food, housing, and healthcare infrastructure. When applied to food allergy, Black children often received delayed or incorrect food allergy diagnosis, not due to clinical oversight alone, but due to the fragmented referral pathways or even misclassification, clinical misrecognition rooted in structural neglect. So the clinician takeaway for this pillar is to look for the upstream factors that funnel children into late stage emergency care rather than timely allergy referral. So, what policies or institutional norms have shaped the clinical encounter before the patient even walks through your door? That's the question for our clinicians. It emphasizes that structural recognition helps prevent the misattribution of disparities to individual choices or worse, group pathology. With impact articulation, we are developing an extra clinical language of structure. This is defined as the capacity to describe how structural forces affect individual health trajectories, provider decision making, and institutional patterns of care. The key concept here is that clinicians must cultivate a vocabulary and frameworks to name how racism, institutional policy, and health systems shape care. When applied to food allergy, terms like clinical misrecognition, which I just used, referral bias, medical mistrust, and even racialized symptom interpretation gives providers new tools to interrogate their practice. And the clinician takeaway here is that this competency expands our vocabulary beyond traditional clinical or pathophysiological terms to include language of justice, policy, and power. Next, we have thought reorientation or rearticulating cultural presentations and structural terms, which is defined as a deliberate shift away from culturalist or individualistic explanations of health disparities towards structural interpretation. So instead of attributing health behaviors or outcomes to cultural beliefs, structural competency asks, well, what systemic conditions produced this presentation? When applied to food allergy, a provider might interpret a Black mother's advocacy as over anxious, aggressive, or non compliant, rather than recognizing how pattern dismissal by the healthcare system has shaped protective behaviors. And we ask clinicians here to shift from what's wrong with this family to what structural factors have shaped this clinical encounter, rather than asking, well, why didn't the family follow up when they were given a diagnosis of food allergy? We instead ask what systems made follow up inaccessible, unlikely, or unsafe? Is it that clinic hours are typically 9 to 3 when many parents are working or children are in school? Well, in Contours of Care, the accompanying case studies, which will be read towards the end, are not just illustrative, they offer an invitation to see structure and story. Now, this part is really important to note as a maternal child health scholar, training scholar, and practitioner. Based on my findings, there are several overlaps within the national maternal health crisis and pediatric food allergy diagnosis and management. Pediatric food allergy disparities are vividly captured in seminal articles such as Riggs' 2023 one, where they document pervasive experiences of provider dismissal, implicit bias, and non responsiveness to caregiver concerns. These patterns mirror those in the Black maternal health crisis, where structural racism shapes clinical decision making, leading to adverse health outcomes, which are notably preventable. So while healthcare access is frequently posited as the explanatory factor within social determinants of health literature, in contexts such as Black maternal health and here, pediatric food allergy outcomes, racial disparities persist, irrespective of socioeconomic status, insurance coverage, or even geographic location. And for me, this signals the need to transcend mere cultural humility trainings or cultural competency trainings, and instead embrace structural competency, which provides an opportunity to produce rigorous institutional audits and robust accountability for institutions. Next, we move forward to practice implementation or observing and intervening on structural interventions. This pillar is defined as the translation of structural insight into tangible interventions, policies, and quality improvement initiatives. The key idea here is that clinicians hold meaningful agency. They can advocate for institutional norms and institutional reforms. They can collaborate with public health partners like me, like you, and participate in reshaping institutional practices that reproduce inequities. When applied to the food allergy context, this session itself functions as a structural intervention, as it did in the fall when this was applied to a hospital training team there in New Orleans. This opens the possibility of envisioning integrating such approaches into clinical onboarding or piloting diagnostic protocols that explicitly account for bias or different access to care. When presented, the clinician takeaway here is that some of the most consequential interventions occur beyond the exam room through policy engagement, equity focus, quality improvements, that QI is very important, and sustained community partnerships, key sustainability. Endeavors in which, these are all endeavors in which clinicians can actively participate, time permitting, they could also lead. And lastly, we have skill development or developing structural humility, which is defined as the ongoing cultivation of knowledge, humility, and interdisciplinary tools needed to disrupt structural inequity. The key concept here is that, like cultural humility, this is a lifelong commitment and it rejects mastery in favor of sustained interrogation of power, bias, and complicity. It's not a one time training or a box to check, in short. When applied to food allergy, Black children continue to experience life altering delays in diagnosis, even in elite medical centers, which is evident in both case reports, one of which we will read today. So the clinician takeaway here is to stay attuned to how privilege and positionality shows up in practice and how it may have previously shown up in the patient's experience. As one of the most humanizing domains here, this is an acknowledgement that the structures we work within, that we are operating within, are complex, dynamic, and bidirectional. Let's discuss the policy pathways. Let's discuss solutions. So, within the federal landscape, the federal policy landscape, there are two legislative efforts that emerge as particularly relevant to this shift toward structural accountability. First, there is the Protecting Children with Food Allergies Act, which seeks to improve school-based care. Remember, that's where 1/3 of cases occur. So, which seeks to improve school-based care, reduce stigma, and lastly, standardize diagnosis and management protocols in educational settings by addressing institutional preparedness, provider training, and emergency response within federally funded child nutrition programs. So, distinctively, this bill reframes food allergy safety as a public health responsibility rather than an individual family burden. And this was reintroduced this Congress back in April. This may look like a peanut-free school, for example. And next, we've got HEA, or the Health Equity and Accountability Act, which seeks to reduce racial, ethnic, health disparities through increased access to culturally appropriate health care, disaggregated data collection and reporting, and health workforce diversification. So this comprehensive omnibus bill is aimed at eradicating health disparities across the U.S. healthcare system. And although it's not specific to food allergies, HEA provides a policy infrastructure that supports diagnostic equity and systems level reform. So this bill has been introduced every Congress since 2007, with earlier versions dating back to 2003. That's nearly 2 decades, but it hasn't yet been reintroduced this Congress. So this bill here is led each Congress by the Congressional Tri-Caucus, which, as you may know, includes the Congressional Asian Pacific American Caucus, the Congressional Black Caucus, or the CBC, and the Congressional Hispanic Caucus. Notably, the Protecting Children with Food Allergies Act does not mention equity at all. And here, a bill that spans over 1,790 pages does not mention allergies. As a federal lobbyist, I see many opportunities for growth and expansion here. Also, as part of my doctoral study, I am developing a mock program, not a bill or policy, but a program that is tailored from the CDC's National Asthma Control Program, which again, I'd be delighted to expound upon at session 2. So this didactic session is anchored in structural competency and narrative inquiry. It invites you to explore diagnostic delays not as clinical anomalies, but as structural outcomes. And as you may know, for our prospective students and those who are considering studying here at this illustrious institution, as a reminder, narrative inquiry is a qualitative research approach that explores how individuals construct meaning through stories and emphasizes in-depth understanding of the human experience in addition to the numerical data. So here is a case study that is titled Tying the Ends of the Rainbow, Delighting in Diagnosis. I will go camera off as I read this somewhat lengthy commentary. Here we go. Even with 6 college degrees between us, even with 2 6-figure incomes, even with private insurance and a home in a well-resourced mid-Atlantic suburb, none of those markers of safety shielded us from suspicion. None of them protected us from the quiet violence enacted across clinical encounters. Even wrapped in every form of social advantage that is supposed to buy protection, we were still read through the racialized lens that too often marks Black families as suspect before we even speak a word. At 8 months old, my child was violently vomiting and had diarrhea, symptoms that merited urgent evaluation. But before we even left triage, a nurse took a quick glance and declared it a BRUI, or in the medical field, that's short for brief, resolved, unexplained event. She told us to go home. When I resisted that dismissal, she shifted to asking whether we were experiencing food insecurity or homelessness. Why were they trying to stay here in the hospital? The message was unmistakable. Our child's distress was viewed as a misuse of resources, an inconvenience, an imposition, and not a child worthy of care. Once admitted, the harm deepened. Specialist by specialist, diagnosis by diagnosis, the system worked harder to pathologize our child than to consider the most straightforward explanation. Neurology evaluated him while he slept, and a neurology fellow, still in training, labeled him with weak limbs and a possible neuromuscular disease based on that single observation. She refused to return once he woke. Instead, she asked if there had been smoking of any kind in our home. and speculated about substance use during my pregnancy. This is clearly written by the parent of one of the children who experienced this. A whispered note of developmental delays appeared in his chart as well, not based on developmental evidence, but on assumptions. Our Howard University trained pediatrician eventually helped us fight to have it removed. Genetics entered the picture. Before considering food allergy, before acknowledging the obvious gastrointestinal symptoms, they asked whether rodents had gotten into his food, a question soaked in classist and racialized presumptions. Then came another, whether I had, and this here is in quotes, any sliver of information about the child's father or a way to contact him, even if through social media. My husband, Dr. C, was just a few feet away, barred from entering the room due to COVID era restrictions that allowed only one parent at the bedside. Still, they assumed fatherlessness, instability, and neglect before considering allergy. Soon after, we were told our infant likely had a seizure disorder and a rare blood disease. We were handed prescriptions for powerful, life altering medications. I refused. I asked for more testing. My insistence, my maternal clarity, was interpreted as, in quotes, non compliance. But I persisted. Over several inpatient days, further testing confirmed what my intuition had known: no seizure disorder, no rare blood disease, just an undiagnosed food allergy, missed, dismissed, and delayed. Given the circumstances and the urgency to identify safe foods, I personally requested a consultation with a registered dietitian. I explained that I had lovingly prepared every single puree from scratch since introducing solids at 6 months old, and I now needed guidance on safe commercial options. The registered dietitian appeared baffled by the question, and she handed me a list of baby foods covered by WIC. The connection she made between us and public assistance was clear, and it was cruel. My son, an infant, not yet forming words or having even taken his first step, had already been folded into a narrative of deficiency, already cast as a pathology to be located, already treated as a problem to be explained through social dysfunction rather than clinical possibility. In all of this, every dismissal, every assumption, every misdiagnosis, because no one considered the simplest explanation first: a food allergy. Today, we delight in our diagnosis. We rejoice in the clarity it brings, the tools, the knowledge, and the community. We can protect them. We have joined the 1 in 13 families navigating pediatric food allergy in the United States, a path marked by vigilance and hope. Food allergies may present late or without textbook symptoms. They may be met with disbelief, delayed diagnosis, or racialized suspicion, but they are real and they are survivable when taken seriously. With earlier recognition, with structurally competent care, our children can live vibrant, joyful, and healthy lives, even if that means they must pass on snacks beloved by so many. They too will thrive. So now and always, I stand hand in hand, tying the ends of the rainbow with every parent navigating the sacred terrain of special diets and medical resistance. May we find delight in diagnosis, strength in solidarity, and courage in every consultation, even when it hurts, even when we're tired, and even when we wish we could simply be mothers instead of warriors. That is powerful. So that leads us here. where I will open it up for a dialogue. I've got some questions listed here, you see. First is, why were rare disorders prioritized over common conditions like food allergies? What would you say are the long-term consequences of inaccurate medical records and diagnostic errors? And lastly, how should misdiagnoses be addressed or redacted in the medical records? So I will open that up for anyone who would like to answer any of these questions. And again, Cassie, please help if someone drops in the chat or raises their hand. Okay, I'm unable to see on my end. I cannot see the participants or any engagement that may be happening. So we will actually pause this slide and come back to it. But if you would like to answer that, please make yourself known and Cassie will absolutely call on you. And in the meantime, here's our post-session survey, guys. We made it to the end. Again, if you're unable to access a QR code for any reason, there is an anonymous survey link that Cassie will soon be dropping in the chat. So, strategic advocacy recommendations. How do we move forward? My proposal is to advance federal policy to address food allergy disparities. So, a priority intervention would look like advocating for the explicit inclusion of food allergy disparities in the Health Equity and Accountability Act, that huge omnibus bill, and for a dedicated objective in Healthy People 2030 focus on diagnostic equity. I would expect an outcome that looks like elevating food allergy disparities as a policy priority, which would then, of course, direct funding, research, and programmatic support toward interventions aimed at improving diagnostic equity. Secondly, I recommend embedding structural competency and diagnostic equity in medical education. A priority intervention would look like partnering with the National Medical Association, the American Medical Association, and or the Association of American Medical Colleges, or the AAMC, and of course, medical schools to integrate structural competency and diagnostic equity content into pediatric and allergy immunology curricula. And an expected outcome here is improved provider awareness of structural drivers, more accurate and equitable diagnostic decision making, and reductions in racial disparities. If implemented, these recommendations would advance diagnostic equity by reducing delays, improving clinical decision making, embedding structural awareness in medical education, and ensuring that policy frameworks explicitly address food allergy disparities. Such changes would move pediatric food allergy care closer to the ideals of equity, justice, and most importantly, institutional accountability, which then transforms contours of care, a public health perspective on food allergies, from a conceptual framework into a model for systemic change. Thank you very much.
Thank you so much, Denise, for that wonderful public health discovery seminar series. At this time, we're going to open it up for a Q&A. So please feel free to drop your questions in the Q&A chat. And then also, I know, Denise, you were trying to get some engagement with that last slide. And so if you want to, you can also, as she's pulling that slide back up, drop with answer those questions as well in the Q&A chat as well.
Yes, I'm dropping the questions in the chat for anyone who would like to answer. And thank you, Cassie, for dropping the link for the post-survey,
You're welcome.
post-session survey. And if there are not any questions, I thank you for your time, for your participation, and for your engagement. I will now drop my email in the chat as well for anyone who would like to continue the conversation.
So we have a question. Are there
Okay.
any government reforms to handle this case?
Any government reforms could you ask that again, please?
Yeah. So it says, are there any government reforms to handle this case?
Yes, those, well, none that are existing to a level that I believe are appropriate, which is why I suggested some legislative pulling on those policy levers within, oh, thank you, Cassie. Uh, for federal legislation, I mentioned, updating HIA or even the Protecting Children Food Allergies Act, in addition to embedding structural competency into our schools, the training, the education, even if that means graduate medical education. And I believe that our federal partners could provide support and assistance with that. By funding those changes to curricula and such. And I also mentioned that I am developing for one of my courses. Um, okay, I see that question. Yep, I am developing a tailored CDC program for addressing this as well, which is tailored by the CDC National Asthma Program. Yes,
So
I hope
I'm
that answers the question.
Yeah, so I'm also dropping in the chat those questions that Denise popped up as well, just in case somebody didn't see them. So I'm gonna drop them in the chat as well for you guys. So, but please feel free to ask more questions. Also, I dropped Denise's email in the chat as well. Um, Feel free to ask her any question about her public health discovery seminar series. If you are a prospective DRPH student for the social and behavior sciences program, I'm pretty sure that Miss Denise
I
will
would love to.
love to connect with you as well. Um, but please feel free to drop those questions in the Q&A chat.
Yes, I'd be delighted to speak with anyone about the program. It's been one of the richest experiences within my academic journey, which dates back to 2006. I'm now at the 20-year mark since I started undergrad. So please feel free to reach out, and I'd be more than happy to share insights about my experience here.
Okay. Another question. The red disorders were prioritized due to the supposed cost to state if it turns out to be a disaster, and they somehow try to handle that rather than focus on simple solution and diagnosis. And I think that's probably an answer to one of your questions.
Could you repeat that, please? I don't believe that I see the chat. So yeah, so
Yeah,
you can repeat that.
yeah. So it says the rare disease were prioritized due to the supposed cost to the state if it turns out to be a disaster, and they somehow try to handle that rather than focus on simple solutions and diagnosis.
Oh, what a great perspective. Thank you very much for sharing that. It's actually much more expensive testing for genetic disorders and things of that nature before considering food allergies. And one of the points, the case study I shared today was condensed. But one of the points that is mentioned in the beginning and I believe towards the end of the case study is that this is a baby, an 8-month-old, an infant who presented with vomiting and diarrhea, a baby that was exclusively breastfed until beginning solids or the purees beginning at 6 months. So food would typically be one of the questions that will be asked. I mean, that's understood, right? Because if rodents got into the food was asked, correct? Versus did they eat something that may have caused this? Yes, that was considered as it relates to rodents versus an allergen. But I do appreciate that perspective. Thank you.
Alrighty. Is there any more questions, or if you're at answering those questions that Denise proposed to you all during the seminar, please feel free to drop them in the Q&A chat. Um, Another comment, I think telemedicine could address misdiagnosis.
Mm, that's a great point. I love that. Thank you very much for sharing. Absolutely. And that also improves access, right? So if we are talking about parents who are busy at work, children who may be away at school, or parents who may have issues or challenges related to transportation, let's think about the rural areas as well, right? Or the cost of transportation in more urban areas. Weather-related conditions that may stop someone, prevent someone from going into a clinic or an office. So I absolutely love that point about telemedicine and COVID. All of this, based on the case study, occurred during the COVID era. So agreed, telemedicine, COVID has taught us just how effective that can be.
You mentioned another case. Would you mind sharing that one?
Yes. So that other case, based on time, I won't have the opportunity to read the full case. But the other case, I should also share, um, there are clinical there are clinic reports, case reports that are paired with case studies. So when presenting this work to clinicians, I provide the clinic reports and they review what would appear to be directly redacted from an electronic medical record, for example. Okay, they would be reading what another physician has drafted about said patient. And the case report, which we love here in public health, me personally, provides a greater context, like this mom who talked about those social determinants of health being facilitators or barriers. So the second case report and case study talks about a child who also had food allergies, specifically peanut and seafood, shellfish, who was dismissed by providers. And told, well, you never tried it, so you really don't know. And there was a very important test that was missing due to, I would say, diagnostic inertia. They were like, okay, it's probably peanuts. He'll be fine. And they did not run additional tests to discover whether or not the child had a confirmed allergy related to shellfish. And the parent then had to advocate for that because this parent was able to read the medical document, understand it, and see what was missing. They then requested that, and it turns out the child was allergic to shellfish as well. But had they not advocated for this missed test or to be taken seriously within the clinic room, this child could have had an adverse outcome or encounter. And also, this child was not provided what is called an oral food challenge, which is standard procedure with food allergy diagnosis. Typically, I'm not a clinician, as you all know that. So, typically, a child whose blood serums shows a possible allergen, they're usually confirmed with an oral food challenge. And this child was not offered that opportunity until the parent requested it.
Thank you so much, Denise. And so, do we have any more questions?
Oh, well, thank you all so much for the engagement. I would like to share now as we end that these are actually my stories of my babies, Salam Mitchell III and Daxton Mitchell. And I share this not to seek out sympathy, but to explain not only how the personal is political, but also how this impacts all of us, okay, across every geographic region here in the United States, across every socioeconomic status here in the United States of America. So often we forget that these narratives are paired with names, right? And that the data points are personal experiences. So the case reports and the clinic and the case studies were both written by me, pulled directly from my children's medical chart for the case reports, and the case studies were written by me along with my wonderful, wonderful, wonderful preceptor, Dr. Margaret Huntworth, there at the Tulane University School of Medicine, who is an allergist, pediatric allergist, who worked with me all of last fall to complete my APE, for those who may be familiar with that. And I thank you all so much for joining and for being a part of this very important conversation in this evergreen, emerging public health issue.
Thank you so much, Denise, for your Public Health Discovery Seminar series, and especially thank you for sharing your story with us. Thank you all so much for joining today's Public Health Discovery Seminar series. Please tune into the next one that will be hosted on February 24th. Thank you all so much. You all have a wonderful Tuesday and take care.
Goodbye.